Hello and welcome to this part of the blended learning for medical gases administration for those of us that are working for emergency rescue solutions. Throughout this training, we're going to refer to a range of reference material, and ERS has got an account with the British Oxygen Company for supplying medical gases. And if you go onto their website, you can find some training resources which are free of charge for both oxygen therapy and for Entonox training, and particularly for the pre-hospital environment. And I would recommend it's well worth going on there and looking at those additional training resources. As well as that, we are also affiliated with QualSafe Awards, and we will be offering qualifications for administering medical gases via the QualSafe Awards, and we'll be looking at doing this as part of the FREC training, but it can be done independently. We'll also be using a range of paper material that you may already have, so books and stuff, and you may have your own. Very commonly people do use the First Responder Care Essentials, as we know you may be using this for your Community First Responder Award. And all of them are relevant, just make sure they are up to date with current best practice. So let's go and have a look through this course. Now, if you haven't already, grab yourself a pen and paper. I will be asking you questions as we go through. If you want to, pause this video as I ask the questions to give yourself time to write it down or to think about it, then I would suggest that's a very good way of learning and testing your own knowledge. If not, after a short pause, I will reveal the answers. So let's have a look first of all at the two most common medical gases that we're talking about, and as previous mentioned, these are both oxygen and Entonox. But please be aware that Entonox is only a trade name. So what we're actually looking at here is the nitrous oxide is the actual gas that we're talking about. Entonox is a trade name used by BOC, but is commonly used out there. Oxygen itself is also referred to as O2 by its chemical symbol. And we do use the code of OXG. Now this is relevant from the JR Calc, and in medical documentation we may use codes for when we're writing administration of gases down, just to shorten it. So that's the one for oxygen there. Oxygen is great. We'll talk about oxygen quite a bit more detail, but essentially it is used to treat hypoxia, which is low oxygen levels, and normally in the teaching environment I kind of use the similarity of talking about your car and thinking about your car engine, and particularly if you've got a petrol or diesel engine, not an electric one, but you would appreciate that your engine has oil in it. You would only top up your oil in your engine if your oil was low, either by a light coming on your dashboard or by you checking and finding out it's low. You would then top it up, and you would top up that oil appropriately to how low it was. So the lower the oil is, the more oil you put in. If there's only a little bit below the line, you only put a little bit in. And that is very, very similar when administering oxygen. We only give oxygen to those patients that require it, and if they're very low on oxygen, we give them lots of supplementary oxygen. If they're only a little bit low on oxygen, we only give them a little bit of oxygen. But we'll talk about that in more detail as this goes on. The oxygen that we are going to be administering comes in cylinders, and there are a variety of different cylinders. We generally use portable sizes, although there are bigger sizes available on ambulances and in buildings. So you may come across one of these ones. The relevance of this is understanding the law and about travelling with compressed gases within your vehicle. So do make sure you read up on the Ministry of Transport and the legal aspect of transporting compressed gases in your vehicle. From my understanding of it, we can carry up to 1,000 litres of compressed gases in our vehicle without having any markings on that vehicle. So for example, if we had a CD oxygen cylinder, you could carry up to 2 of those. But if you had a ZD cylinder, you could only carry 1. But the markings for it may be as simple as a magnetic or a window sucker or a sticker on the back of your vehicle to indicate that you're carrying medical gases. So Entonox then, or the nitrous oxides, the code that we use for writing down that is known as NOO, N-O-O. It is an analgesia, so Entonox is a pain relieving gas, and we will talk more about this as we go through. And again, this does come in a variety of sizes, but the most common one that we get, and we get it from the BOC, is the ED size cylinder. So in comparison, it looks the same as the CD or the ZD cylinder, but obviously containing that Entonox. And we'll talk about the colours and stuff as we go along now. So oxygen itself, or O2, let's have a little talk about this. So the guidance that we get from this, as we mentioned earlier in the slides about the teaching of this, we are going to be looking at different resource information, but if we go back to the raw roots, it's actually the British Thoracic Society of where we get our guidelines from, and that's not a bad place to be able to reference to, because that's the kind of the raw roots of this. Commonly in the pre-hospital environment, we refer to the JR Calc, but the JR Calc gets all its information from the British Thoracic Society and puts it into pre-hospital emergency care kind of script for us to use and guidelines for us to follow. So it would be an idea if you had access to that, whether in paper form or digitally, even if it's just the pocket guide, it is a useful information. Having the electronic version does give you the advantage of it being kept up to date as things do change on there. So things that I believe that you need to know about oxygen, because I often find that people within the pre-hospital environment, first aiders, etc., quite often dismiss oxygen as just being a normal kind of part of doing first aid. Well, it's not. Oxygen is a prescription only medication, so I really strongly believe you need to know all of the cautions with using oxygen, so the explosion problems with it, defibrillating with it, etc., but you need to learn those cautions and understand them. You need to know when to give oxygen, and we're going to be talking about that in this session. And you need to know when not to give oxygen, because it can have detrimental effects on some patients. And the last thing is you need to know how to give oxygen. So in the practical element, I'll be doing a demonstration later on in this video, as well as we would expect you to get hands-on experience, and we have got a range of training kits that you can use to get experience before using them for real. So let's first start with why oxygen. What a question. Why do we give oxygen? So there's a question for you, and this is something you can write down or think about before we kind of move on. Why do we give people oxygen? Well, that kind of brings me on to the question of why do we breathe? So if you want to pause the video here, please do so and have a think and a write down about that. Why do we breathe? If not, I'm going to carry on and explain why we actually breathe. And it's not what most commonly the answer I get back is because we need oxygen. That is not the case. Actually, the reason we breathe is because our brain registers high levels of carbon dioxide within our blood vessels. carbon dioxide written as CO2. So when our CO2 rises up and becomes to a certain amount, our brain that registered that will then tell our diaphragm, and it will use the phrenic nerve to send that message, that we need to breathe. So the diaphragm then lowers, which increases the cavity space within our thoracic area, and because the area has been enlarged, we need to fill that area with something, so air gets drawn in through our airway, so through our nose, our mouth, down our trachea, and into our lungs. That air contains what? So again, another opportunity for you to write down. So if you'd like to pause the video again here, please do so. But what is contained within the normal atmospheric air around us? So I'm going to look approximately at these figures. You may find more detailed information when you research this elsewhere. So basically, we're looking at 21% of the air around us is made up of oxygen, technically 20.8%. There's no carbon dioxide. Well, it's 0.04%, so very, very small amount. Actually, the majority of the air around us is made up of nitrogen, and there's a little bit of inert gases as well. For the purposes of this training video, when we breathe out, what comes out? Well, again, I'm going to explain this. It doesn't come up on the PowerPoint, but what comes out is 78% nitrogen. So for the purposes of this, nitrogen just goes in and comes out. But under different pressures, diving, flying, etc., our body reacts differently and will use nitrogen in different ways. But we're not going to go into that in this teaching session. When we breathe out, we get about 16% oxygen coming out, thereabouts, which means we have lost some of that oxygen because it has been used up within the body, and that's what we're going to go on and talk about. So what makes up the gap of what comes out is carbon dioxide. We actually breathe out about 4-5% carbon dioxide. So let's go and talk about that in a little bit more detail. So where does the carbon dioxide come from? Again, an opportunity for you now to answer that question. Write it down, think about it, say it out loud, and see whether you agree with what I'm going to go through now. The carbon dioxide that comes out is a waste product which is produced within our body. Cellular activity produces that waste product. The other waste product it produces is water, or H2O. Our cells need a fuel to live, and that fuel is oxygen. But it also uses the food we eat and converts that food, the sugars, into glucose, and we use that as part of our fuel. So the oxygen and the glucose are our fuel, and they are both transported around our body via the circulatory system. So our blood is the carriage within our blood vessels which carries the oxygen. The oxygen attaches itself to the red blood cells, the hemoglobin, and it goes to the cells as a fuel. That causes a waste product, the CO2 and the H2O, and that's what we breathe out. So we need oxygen to help fuel our cells, not to breathe. Hopefully that concept makes sense to you, but if not, have a read up about it. There are some very good YouTube videos you can watch which describe that in more detail and more technically, but that's the real basics that we need to understand. As the body changes because of medical conditions, maybe trauma, then some of these processes will change, because what our body is trying to do is create equilibrium and homeostasis and keep itself at the correct level. So it will put some processes in place to create that and try and stay as normal as it can. So why are we going to give somebody supplementary oxygen? So we're talking about our patients now. What do you think the answer is? Well, I've given you lots of information already, and you may already know about this, but make a couple of notes for yourself. Why do we give somebody supplementary oxygen? And just as a side note, that oxygen is only going to be beneficial to them if it is above 21%. Because if we're giving anybody less than 21%, we're actually starving them of what they would normally have in atmospheric air. So there's a consideration for us as well. So the main answer is we only give somebody oxygen because their oxygen levels are low. So the next question leading on from that is, what has caused their oxygen levels to become low? So there's something for us to think about again. So what are the normal oxygen levels and how are you going to measure it? So hopefully you're now writing down a number or a range for me, because it's about to appear here now. So yes, we have this range here, which is 94 to 98%. That range is quite important, because it is different when you talk about in hospital and we talk about things like the NEWS score, the National Early Warning Score used for sepsis and things like that, where in hospital they talk about 96 and above. But in the pre-hospital environment, and this comes from the British Thoracic Society and is then used in the JR Calc, we talk about 94 to 98% is the normal range of SpO2 on an adult, and that would be measured on a pulse oximeter such as we can see up here. So this is just one example of a pulse oximeter, and the basics of how this works are covered in a different session, but really basically you place the patient's finger inside this and it comes up with two measurements. One of them will be the pulse rate of the patient and the other one will be their oxygen level. Very rarely do small machines like this come up to 100%, so the most it would ever give is 99%. One thing that I would highly recommend is that you learn what can go wrong with these pulse oximeters, such as the batteries being flat. So testing your equipment is vital, but there are other things and other reasons why it may not work correctly. There's a whole range of things, so you should have a look and go through that. I will give you just a couple of quick examples: cold hands, shivering, carbon monoxide poisoning, vibrations, bad circulation, Raynaud's disease, ambient light. Just a couple of examples of why a pulse oximeter can go wrong. If you are working with a COPD patient, so a patient with chronic obstructive pulmonary disease such as chronic bronchitis or emphysema, and they've been diagnosed with hypoxic drive, then their normal SpO2 range would be 88 to 92%. Now this is really crucial, but I'm not going to go into it in a lot of depth because we're more interested in our trauma patients, and working for ERS we're unlikely to come across a COPD patient, and if we do come across a COPD patient and we're treating them for trauma, we would still give them the high level because it's the treatment, not their medical condition that we're treating. Now the significance about the hypoxic drive, so this little bit here, is these patients have lost their ability for their brain to register levels of CO2. So their brain now registers low levels of oxygen. If their brain registers when they've got low levels of oxygen, if they've got high levels of oxygen, their brain doesn't register that, so they don't register to breathe. So if somebody with hypoxic drive, you gave them lots of oxygen, you would then be causing them to lose their ability to breathe, or their drive to want to breathe, which means you could stop them from breathing. So anytime we administer oxygen, it's important that we've already done a respiratory rate before the administration of it and during it, and we document this down in our patient clinical records, or however we're doing it. But we will have patient clinical records which we will expect you to complete for ERS as a company, and you're handing them back into the office. So it is important you do that. So we can go on and talk about what the normal breathing rate would be in a second, so we'll come to that. But the other thing is, if you haven't got a pulse oximeter, or your pulse oximeter is not working correctly, maybe for one of the reasons I mentioned earlier, or something else you can think of, then we can look for other signs. What are them other signs going to be? That's right. We're talking about signs of hypoxia, low oxygen level, and one of the key signs is cyanosis, and that is the bluish tinge around the peripheral extremities. So they start to look very pale blue around the lips, maybe the tip of the nose, the ears, the fingertips. They've got poor peripheral circulation, so that would be something to look out for. If it is medically or clinically indicated that oxygen is going to be beneficial, we would also use it, so for things like in a cardiac arrest. But you also need to be aware of when oxygen, supplementary oxygen, can be detrimental, then we can avoid it. So that brings me nicely on to the properties of supplementary oxygen. So we know there's oxygen in the air around me, but the supplementary oxygen going in is going to cause adverse effects on the body. So what properties does supplementary oxygen have? Excellent, good. So, I thought I had the answer coming up on there. I do apologise, I flicked onto there. So, oxygen is a vasoconstrictor. So let's go through this now. So this wording comes from the JR Calc. So I'll go through this slowly and come back to that properties of oxygen there in a second. The JR Calc actually state oxygen assists in reversing hypoxia by raising the concentration of inspired oxygen. Hypoxia will, however, only improve if respiratory effort or ventilation and tissue perfusion are adequate. If ventilation is inadequate or absent, assisting or completely taking over the patient's ventilation is essential to reverse hypoxia. So, what is the normal adult respiratory rate at rest? So this is the point where I want you to write down either a number or a range before I reveal it. As per the JR Calc and the British Thoracic Society, the normal adult respiratory rate at rest is 12 to 20 resps per minute. So again, another important one that we know this and that we document it, and how we accurately would calculate that is important. As we know, in the pre-hospital environment, we should be bare below the elbows, so we should not be wearing a wristwatch. So I would recommend either a fob watch or using your phone. I would personally take a respiratory rate over 30 seconds and then double my answer. But if I was unhappy with the breathing, I would always take it over the full minute to calculate it accurately and correctly, because remember, you're going to be documenting this, and this is a medical record that may be requested by the coroner or any other investigation that takes place. So medical records are important, and you cannot lie on a medical record. I would much rather you turn around and made a side note and said I was unable to get a respiratory rate at that stage. That would be much better, so we understood that, rather than lying and just writing down anything. But the more accurate you can get it, the better. So what is considered an inadequate respiratory rate? And it is quite difficult to find references to this, and there are a couple of different books which mention a couple of different scales. But what would you say it is? I'm going to quote from the JR Calc again, and the range that they give us is anything below 10 or above 30 rests per minute. So that would mean that this patient has also got hypoxia and is normally would be unresponsive. If somebody is breathing at 35-40 rests per minute and they're still got adequate oxygen in their body, so they're good colour, they're still kind of able to talk some words and bits and pieces, we wouldn't worry. But if they're unconscious, they look hypoxic and their breathing is very fast, and again, just as a side note, what's the technical name for fast breathing? So technically any breathing above 20 rests per minute would be known as, good, tachypnea. Tachy meaning fast, pnea being to do with a breathing. And then anything below 10 rests per minute would also be a consideration for us. Not that they use this word, but I suppose bradypnea would be what it would be known as. But if they are breathing less than 10 breaths per minute, and this can often see in times of things like an opiate overdose, because opiates can be a respiratory and a cardiac depressant, or may be seen in other incidences, head injuries, etc. We then need to consider using a bag valve and mask to actually breathe for the patient, squeezing that bag once every 5 to 6 seconds. Remembering the adult bag valve and mask is normally about 1500 milliliters. The average adult respiratory intake is about 500 milliliters, so you only need to squeeze about a third of the bag. And it is always best, or it is the gold standard, to use the two-person technique if available. So one person from above the head holding the mask onto the patient, their mouth and nose, pulling the angles of the jaw into the mask, which is the jaw thrust, which opens up the airway, allowing the second operative or second medic to gently squeeze that bag and making sure you don't overinflate, because any overinflation would then put air into the stomach and not be as effective. Remembering that normal breathing happens from the diaphragm lowering and it sucks that air in. Now we're forcing air in, we could force that air the wrong way. So considerations need to be considered if using artificial ventilation. Okay, so coming back to that little bit, I jumped around earlier, the properties of supplementary oxygen. So when we're giving oxygen from a cylinder in whichever form, whether it be from a 100% non-rebreathable mask, a simple face mask, a nasal cannula, or we're using a bag valve and mask, but we've connected it to that compressed cylinder, The oxygen has 99.1% purity, so we often refer to it as 100%, and we know that oxygen supports combustion. But what oxygen does to the body is it is actually a vasoconstrictor. So oxygen will actually cause your blood vessels to become narrower. So if they're becoming narrower, less blood can get through them. So I suppose a consequence of that could be a slight raise in blood pressure. But think about times that we would actually want our blood vessels to be narrower. So for example, if we had particularly low blood pressure, the patient had suffered from a syncope, a fainting episode. In high trauma, maybe they're bleeding, so we're going to constrict those blood vessels. And think about times we would not want to give them oxygen, so when it would be detrimental. So thinking about times with the blood vessels that there might be an embolism, a blood clot in those blood vessels, such as a heart attack, a myocardial infarction, an ACS, an acute coronary syndrome. I just mentioned all the same things but given them different names. It could be a stroke, so they could be having a CVA, a TIA. So a clot within the brain possibly. Or it could be a PE. Now that comes under something different because of the breathing element. We could well be giving them oxygen during that, but it's well worth focusing on the different lists that the JR Calc give us and understand why each of those conditions is on that list, and the understanding of why will then make us a much better medic and understanding why and when to give supplementary oxygen. So we need to understand the benefits. Please don't just give someone oxygen because I can. That's not a suitable answer. The oxygen we give has got to be beneficial to the patient. So remembering it's a prescription only medication and we need to be trained and qualified to administer oxygen, so it must be documented as well, and we must be giving it because there is a benefit to your patient. Really important that we do that. And again, if you understand that, you can understand what problems oxygen can cause, so that if you see them problems, you can stop the treatment of supplementary oxygen and then change to a different method. So really important that you do read up on this stuff and you start to know. So just going to highlight this here. You really do need to know what it says in the JR Calc and the up-to-date JR Calc. The latest edition is the 2019 edition. I believe the next edition is due to come out in 2022, but sometimes there are supplementary updates. So do keep an eye out for those up-to-date JR Calc ones, or go straight to the British Thoracic Society. Okay, so oxygen in summary. So we're coming to the end of oxygen before we move on to the next one. So just to summarize this, oxygen is often referred to or known as O2, so the kind of slang, if you like, that we use for it. And we only give oxygen if it is clinically indicated. So you need to know the red list in the JR Calc, which has got things on it like cardiac arrest, carbon monoxide poisoning, major trauma, anaphylaxis, decompression illness, major pulmonary hemorrhage, sepsis, shock, drowning, and actively convulsing, as well as hypothermia. And each and every one of those we could delve into a lot deeper and actually start to understand what that condition is doing to the body and why it would need supplementary oxygen, as well as then understanding what's not on the list and understanding why we don't give it unless clinically indicated, because their SpO2 reading is less than 94%. So enjoy reading the JR Calc to make sure you are up to date and understand all of that. Okay, moving on from the oxygen, we're going to go on to the nitrous oxide administration, which the trade name from BOC is Entonox. So let's have a little talk about Entonox. It's 50% nitrous oxide, the other 50% is oxygen. So thinking about everything we've just talked about, the 50% of oxygen that is in this is going to be beneficial to those patients we've just talked about. So you could use it in combination if so needed. The cylinders for this do look different to the oxygen cylinders. Quite often it has the word Entonox printed on the side. It definitely does from the BOC, or it may have the abbreviation for that on there, the chemical formula for it. But the colour blue is often used for indicating an nitrous oxide cylinder with a white shoulder. Sometimes they are quartered to make it easier to identify. So nitrous oxide may have a deleterious effect if administered to the patient with closed body cavities containing air, since nitrous oxide diffuses into such a space with resulting increase in pressure. So that's important to understand, and this would link back to one of the things I mentioned earlier with the oxygen and the air bubbles, and we talked about the nitrogen in the air around us and different pressures, and this is where all of this can become very complicated, and once you understand the basics, it is well worth going on to read the more in depth and how those nitrous oxide bubbles can cause some issues and problems within the bloodstream. So basically like an embolus floating around within our circulatory system, so as you can imagine can cause us problems. So we're going to use Entonox as an analgesic agent. It's a pain relieving gas, and we're going to use it correctly, which will be of good benefit. So that's basically when we're going to use Entonox if our patient is in pain and they're able to self-administer and they can inhale this gas to relieve that pain. So there's just an example of what an Entonox cylinder may look like. Quite often the bag it comes in is also blue, but not necessarily. I know within ERS we've got one of our bags is green and one of them is purple, so we've got a number of different bags that we use. Now there is a step up on this, and there are some cautions because nitrous oxide Entonox can be detrimental to patients, so there are some cautions. What do you think these cautions might be, thinking about the patient's conditions? Yeah, what did you come up with? Let's have a look on here. So if we had a patient who was at risk of having a pneumothorax. A pneumothorax is a collapsed lung due to air being in the thoracic cavity, so that could be a problem. Now, bear with me on this one because those that know me will know I'm not very good at pronouncing big medical terminology and names and reading them out. I'm struggling with English most of the time, let alone these medical ones. So if we have a pneumomedisternum, which is air between the lungs. Okay, so this is between the lungs, basically where the heart is sitting in the thoracic cavity. So again, air in that area would be a problem, and they wouldn't be able to use the nitrous oxide. Pneumoperitoneum, I think, air in the abdomen, the peritoneal area, so that would be a problem as well. So abdominal injuries could be a problem, and especially with air in the abdomen. So something to consider there. Polytrauma, so if they've got multiple injuries, because with polytrauma there is a high risk they're going to have damage to the thoracic cavity, so around where we've just been talking about, so talking about the lungs and even into the abdominal area, and that risk outweighs the benefit on this occasion. And the other one then is if they've got penetrating trauma, so they've got something which is sticking into the body, so piercing through the skin, which shouldn't be there. We would also then not want to use Entonox on them. So that's particularly in the torso area, so where the lungs are. So quite a lot to think about there on that. So contraindications, this is straight from the book. So contraindications, what are these going to be? Have a little write down on what you think this would be. Yeah, so we're not going to give nitrous oxide to any patient with a severe head injury. So minor little bumps to the head may be okay, but if you're a little bit worried whether you should or shouldn't give them the nitrous oxide, the Entonox, then go on the side of caution. The fact that you're worried tells me you shouldn't be giving it. Be confident in what you're doing. So if they've got a head injury, particularly a severe head injury, you're not going to give it. Decompression illness or sickness, so this may be referred to as the bends. So this would be maybe from a diving environment, but not that they've literally just come out of the water. This could be within the last 24, 36 hours. So within the last day or two that they've been diving, and they could be suffering from decompression illness, and it may be that they've just been on a flight as well. So think about that high pressure altitude could cause some complications. Any violently disturbed psychiatric patient, we're not going to give them this because of the effects. We don't know then what's going on, and it could make the situation worse, and it could make them more violent, which obviously puts us in a very vulnerable position, so be careful there. Intraocular injection, so they've had some air injected into their eye. Again, this is one to read up on because this is within the last 8 weeks. What you will find is if they have had an intraocular injection, they should be carrying a medical card on them, which they can show us and we can be aware of. So any operations around the eyes and you're unsure, go on the side of caution and don't give them the Entonox. That's really important. Abdominal pain then, and that's because of the potential of air being in there and depending on what's going to happen with that patient, and if they need to go to surgery, then having the Entonox is not a good way. It kind of causes more problems later on, so we'd rather them not have the Entonox. They may have to manage their pain through another route. They may self-administer paracetamol, ibuprofen, or something along them lines, but that would be self-administered rather than by us. So when can we give the nitrous oxide? When can we get out the oxygen? Well, if we've got a patient who has got moderate to severe pain. So this brings me on to pain scores and how we're going to do this and what questions we're going to ask. So again, if you've got your pen and paper there, write down to me what the pain score is as per the JR Calc. So I am aware that there are different pain scores out there, and you can do different ones, like the Abbey pain score is just another example. But what does the JR Calc state is the range that we will look at, and what are the questions, or what is the mnemonic that we will use? And I know there's 2 different ones that are commonly used out there, but what we're looking for is the pain score is between 0 and 10, 0 being no pain at all and 10 being the worst ever, which means a score of 1 indicates some level of pain. So a pain score is not 1 to 10, it is 0 to 10, because we always go with no pain at all or the worst possible pain. And the mnemonic that we use is Socrates. So we can go through and ask them this and document this as well, that we've gone through it. So in Socrates, as per the JR Calc, we talk about the site. Where exactly is the pain? And we're asking that so we can rule out some of the contraindications and make sure we're not giving Entonox inappropriately. The onset. Where were you? Sorry, what were you doing when the pain started? We're trying to understand the mechanism and how long this pain's been going on, and whether they've used any own pain relief as well. The characteristics of the pain. So what does the pain feel like? So asking nice open questions, allowing the patient to answer in their own words. Please do not use leading questions and make suggestions to the patient. Let them use their own words. We then ask them about where the pain radiates, so finding out if the pain goes anywhere else, if they've got any associated symptoms, and this could be, for example, if they're feeling nauseous or they're vomiting, they could be feeling dizzy, headache, etc. So again, nice open questions for the patient. We can ask them about the timings and the duration, so we can find out how long they've had the pain, or whether the pain is coming in waves, so we can talk about that with the patient, so we get a really good understanding. And we know that quite often cardiac related pain is often continuous there, and abdominal pain can be more in waves because of the way it works through the digestive system. We can ask them about if there's exacerbating or relieving factors. So in other words, what makes the pain worse? What makes it better? And from that information, encourage them, and you do the things that make it better. And that may be positioning the patient. So that's another form of pain relief, is the position that we place them in. So just little things like that will really help. And then encouraging them not to do the things that make it worse. And then the last thing on Socrates is the severity. So that's when we give them the pain score. So given a pain score between 0 and 10, 0 being no pain at all and 10 being the worst pain ever, what would you tell me is your pain right now? We can then document that pain, and if it is moderate to severe pain, so we're looking at, the upper end of the scale. I know in front of us now it talks about a moderate being a 4, 5, and then going up, but I would suggest we're looking at that kind of upper end, that 7, 8 or 9 or 10. Then we can give them that pain relieving analgesic gas, the Entonox. We should always document it again, so we have to go through our secondary survey, our patient observations, and we document it again, so we have got a second pain score and a third pain score, so that we know whether that pain relief is actually any benefit to the patient whatsoever. And if it's not doing them any good, then we need to consider alternatives for them. The other thing we might use it for is labour pains. Hopefully we won't have to deal with this as part of ERS, but you never know what you might come across. Okay, advantages of giving Entonox. It is a pretty rapid analgesic effect if we use it correctly, and I'll talk to you about that in a second. There are minimal side effects to Entonox. Certainly it has no cardiorespiratory depression. So I mentioned opiates earlier. The opiate we commonly use within the ambulance service would be morphine, and that can have respiratory and cardio depressants and cause things to change, but Entonox does not do that. Entonox is self-administered, which means the patient only takes it if they can, and they take as much as they need, and they stop when they don't need it anymore. The effects from Entonox do wear off pretty rapidly. So if somebody doesn't like it, so if they start inhaling the Entonox and it makes them feel strange, funny, weird, then they can stop taking it. From experience, it can have very emotional effects on patients. Sometimes it makes them very happy, giggly and bubbly. Sometimes it makes them very sad and emotional. So you can warn the patient of that. It could be normal if you see that happening. And we mentioned earlier that 50% of Entonox is actually oxygen, so that could be valuable in some of the conditions we talked about earlier, particularly the trauma that we talked about when oxygen is indicated in massive trauma, and even things like burns and stuff like that. Entonox can be used whilst you're doing other things or preparing other medication or waiting for the emergency services to arrive on scene. So this might not be the only pain relief they get. There may be a cocktail of drugs for pain relief that this patient will end up having. But this is one of the best things that we can use if we use it effectively. Some patients may prefer to have a full face mask, but more commonly we will have a bite block, a mouthpiece for the patient to suck on. So the usual precautions must be followed with regards to caring for Entonox equipment, and the cylinder must be inverted several times before use to mix the gases, particularly when in low temperatures. So if we've got it, and quite often the environments we work at, it will be in low temperatures, the gases can separate. So if you are in low temperatures, then it's good practice just to invert the cylinder a few times before you actually use it. As I say, we very rarely use a face mask. We often use the mouthpiece, and we will give them suitable instructions, and we must stay with the patient whilst they're doing it. Do not leave the patient on their own whilst they are using Entonox. So Entonox can take a few minutes to actually have any effect, even up to 10 minutes. And if they're not taking Entonox correctly, then it may not feel like it's having any effect whatsoever. So the procedure for giving Entonox, and we're really at the end of this now. First of all, we're going to open up our bag. Now, within ERS, what we're going to do is put a breakable cable tie on the zip of the Entonox bag. Nobody has any need to check that equipment. The fact that I have put a cable tie on it and I have signed and dated that, that cylinder will be full or nearly full, and the equipment is ready to go for you. If I find any bags, or you find any bags with the cable tie broken on it, you need to report that back to us, because the person who used it previously to you didn't get the cylinder checked afterwards, and we will have a patient report form which will indicate the use of Entonox. What we are trying to do is safeguard against the potential of the abuse of using an analgesic gas. So anytime you use Entonox, it must be documented, and we must have a copy of that paperwork come back into the office. So once you've broken the cable tie, they're easy enough to break. Open up your Entonox. Ensure the demand valve is clean and ready, so just maybe wiping it off with a paper tissue if needed to. Always put a new microbial filter on it, which would be single patient use, making sure they don't breathe back down the tube and contaminate it. You then connect the hose, the Stradar outlet, into the cylinder. So when you take this out the bag, the hose needs to be connected to the cylinder. If the cylinder is brand new, there may be you may have to turn it on, so you will have to turn it on. So once you've connected the hose into the cylinder, you've then got the black dial, which you'll turn as the same as the oxygen cylinders. You need to turn it a minimum of a quarter of a turn, but you could open it up even more to allow the gas to come out. It won't come out on its own. If you do hear any leaks at this stage, switch it all off. Take it all apart and start again. There shouldn't be any noise of any gas leaking out. The only time the gas can come out is if you check the demand valve, and there's a button on the back of the demand valve, and by pressing that you cause the gas to come out. The other way it works is when the patient self-administers the gas, and by placing it in their mouth and taking a deep breath in, you will hear the gas coming out and the patient can breathe it in. And as we mentioned earlier, it's really important the patient is under continuous monitoring whilst using Entonox. Now, so from my personal recommendation, the way in which to take this, I would always encourage the patient to bite the bite piece and take a deep breath in and then hold for a count of 3. 1, 2, 3, and then slowly breathe out. And then do the same again. Take a deep breath in of the gas. Hold for a count of 1, 2, 3, and slowly breathe out. By doing it that way, it's the holding that allows the Entonox, the gas, to get into the bloodstream. If anyone breathes this and they breathe it very fast and they breathe it normally, just breathing in and out, it doesn't actually allow the gas to get into the bloodstream and work. Now again, from personal experience, I have found using this method to be extremely beneficial, and it's actually caused my patients to become unresponsive. They've taken it, it's been so effective that they have actually just been knocked out from taking it. I must admit to you, the first time this happened, it worried me, and I was worried about the patient, but actually understanding that this is actually good because it's effective didn't worry me. Obviously, I then had to go into my airway management techniques and make sure the patient's airway was safe and everything else. But just to forewarn you, if you use this technique, it can have a really good effect on the patient. So to finish us off then, I put on here discussion time. So this isn't with me at this time, this is going to be at a different time, but for you to think about. And this is to think about medical gases. And I've just put on there, what are they? Where are they? Where are they kept on the vehicles? What do they look like? When are you going to use them? Who can you use them? Who can you use them on? Why are you going to use them? And how are you going to use them? So just a what, where, when, who, why, and how. So there's a discussion that we can have at another time. But I think it's really important that you think about all of the different possibilities and the answers. Because with medical gases, you really got to know what you're talking about. So there's an hour session for us on medical gases. You may have broken it down and paused this video and used it in little bite-sized chunks, which is great. But thank you very much for participating and listening and actively taking a part in answering those questions. There will be more training videos like this coming up from ERS in the future. And just as a reminder on the medical gases, there is still the practical element for you to do as well. This is not a recognised qualification. This is just in-house staff training as awareness, and we do have a training oxygen and Entonox set which you are more than welcome to come in and use and practice with and get hands-on experience. But do make sure you get your recognised qualification. And as I said, that qualification from BOC, the online one, is a really good one to start with, but we would like everyone to get the QualSafe or an equivalent qualification, and we would like to keep a copy of your certification on record, so please do send it into the office. We do hope you have enjoyed this training video. If you have, please leave us a comment. And if you would like any other training videos, please let us know and we will do our best to facilitate that. But for now, thank you very much and we will see you all shortly.